people who have achieved a lot of material things, but at the same time, they're extremely sad and emotionally bankrupt. And this whole idea of I'll just buy some therapies for myself, just like I buy food for lunch, it doesn't work, Therapy is not the solution to all the problems, Like a therapist cannot. I'm a therapist, and at the same time, a therapist cannot. It's not no one is a magician, There are some emptiness that a therapist cannot fill, So, for example, they can get you out of a major depressive disorder, but they cannot entirely make you happy. And these are two very different things, So one is dragging you out of a major depressive disorder or from severe anxiety. That's possible by a therapist, by a psychiatrist, or combination of both. But they cannot make you fully happy. And what can make you fully happy is self-awareness, healthy relationships, good food, healthy sleep, like meaningful purpose, and all of those deeper questions.
Absolutely. I think there's a lot of parallel in palliative medicine too, because, we can't always get a cancer pain to zero, right? We can't always make death go away. The inevitability of death is going to be sad inherently, right? So there's a lot of similar feelings for that as well.
So I'm super excited to have a conversation with Dr. Ivy Akhtar, who is currently Assistant Director in Johns Hopkins Palliative Medicine faculty. So thank you for joining in.
Thank you so much, Dr. Amin. It's an absolute pleasure to be here. I was really excited about this platform. I think at first I just want to say that it's such an important platform for the Bengali community to have these different perspectives. So thank you for having me.
Yeah, thank you. It's great that you were able to make time for this Perspective podcast, and I'm super excited. So you are a second generation Bengali. So a brown girl's journey in the world of medicine and becoming the assistant director in a prestigious center like Johns Hopkins University, playing a very crucial role. And you are yet to become 40, married and settled and all of that. So how is it possible to achieve all of that? Because so many of the men and women in Bangladesh feel that, we shouldn't dream so big so early. How was your journey?
Yeah, I can certainly share, a little bit about my childhood and upbringing. So the first thing to know about me is, I largely grew up in the States. I came to New York when I was about 4 years old. So, I did live in several different states after that, but my mom and I really grew up and moved around in a lot of different places as I was younger. And, I think our journey came with a lot of obstacles and challenges, just like, many immigrant experiences have. My mom raised me on her own because my father had passed away when I was younger. And I had, seen her working very hard. She was constantly working, multiple jobs. I was known as a classic latchkey kid. So, that essentially means I was home alone a lot at a very unsafe age. But one of the distinct things I remember that my mom had done is actually she would rent rooms from Bengali families in the community, so I wouldn't be alone all the time. And it was like this beautiful, symbiotic relationship where the families would actually, be maximizing their earning potential by renting out a room. This was like Airbnb before Airbnb became a thing. But I also, had some amount of security as well. But, all that's to say is that I was exposed to the culture, at a very young age to really understand, values of education and prioritizing family. As I said, my father did pass away, but he was a well-known physician. He was a professor at Dhaka University as well. So I think the seed of, medicine was planted at an early age. Yeah.
It wasn't at all easy for a single mom to raise you well. It wasn't easy.
It was, it's two women, right, with very little support. So certainly not easy. Yeah, she had several jobs. And I think like seeing her work ethic and struggle, it kind of fueled the fire and the motivation to be, self-sufficient and independent, just because I had seen her struggle so much.
Yeah, definitely you have made her proud, for sure. For sure. So why Palliative? Yeah. Sorry.
Yeah. So, what I was going to share is like part of my medical training, I actually took some time out during that time to visit my father's village in Joshua. And I also visited a place, I don't know if you're familiar with Pangu Hospital. Is in Dhaka. Yeah. So, and like, there were honestly like very eye-opening experiences for me. There were like 3 to 4 trauma cases, for example, in an operating room, a small boy injured here, a scooter accident here. And it was just kind of incredible to see like the amount of dedication that the doctors had in the hospital. And that was sort of one of the, big experiences that sort of led me to palliative medicine, because it was kind of seeing patients in, like a very critically ill space. And also understanding like there's a very vulnerable population out there that sort of sparked my interest in it. I like to quote Robert Frost poem, I took a road less traveled. Palliative medicine may not be, everyone's top choice, but it's really a way to help people in a time of need.
For sure.
And, it's about helping people when, for example, oncologists may not have therapy for their cancer, or a cardiologist may not have therapy for their heart, but that doesn't necessarily mean that we can't treat the patient as a whole. And so I think that's the aspects of, palliative care that I really enjoy.
No, the situation of Pangu Hospital is still extremely challenging, because the number of unwanted incidents happening in Dhaka or in Bangladesh versus the amount of physicians and amount of resources that we have, it doesn't match at all. It doesn't simply match at all. So the struggle is very real. In fact, I do take my family and I encourage other families to take to Pangu Hospital sometimes, to make children understand and be grateful about life and try to be responsible to help others, because they need finances, they need food, they need security, they need definitely palliative care. They need many things. And so that was also one of the motivations behind why we created LifeSpring Foundation. So we have 2 wings. So we have LifeSpring as a private limited company, which is trying to solve a social problem. At the same time, we have LifeSpring Foundation, where we are raising funds every now and then. Emergency medical fund, we are trying to get into like other people help. So even in this podcast, there will be a appeal for someone's healthcare. So a baby girl who was in a fire incident, a mom who was about to die and husband left, doesn't have any money. So in every podcast, we are also earning a little bit of money as emergency medical care. But I know this is nothing compared to the need, but we are institutionalizing it step by step so that we can improve it. But one of the places definitely where we want to improve is palliative care. That is why we, from Livestream, we already have our wing on palliative care, where there is internal medicine specialists, psychiatrists, psychologists, therapists who are trying. We are trying to put it up, because in Bangladesh, people don't understand why palliative and geriatric care is so critical in overall well-being.
শরীফুল ইসলাম একজন দিনমজুর, দিনাজপুরে ৪৫ বছর বয়স্ক। উনি প্রচন্ড অসুস্থতায় খুব কষ্ট পাচ্ছে, তার জরুরি ৫-৭ লক্ষ টাকা দরকার চিকিৎসার জন্য। আমরা আগের যেই অ্যাপিলটা নিয়ে কথা বলেছিলাম, যেখানে আপনারা এখন পর্যন্ত অলরেডি প্রায় ১.৫ লক্ষ টাকা আপনারা হেল্প করেছেন। আজকেও আমি অ্যাপিলটা করছি, আমি ইয়াহিয়া আমিন ৫,০০০ টাকা ডোনেট করছি, এবং আমরা আশা করছি আমরা সবাই যদি একটু একটু কন্ট্রিবিউট করি, তাহলে ওনার জীবন, ওনার পরিবার সবাই এই ভয়াবহ অসুখ থেকে মুক্তি পায়, যেটার কারণে একটা পরিবার এবং তাদের সন্তানরা সবাই বেনিফিটেড হবে। সো ওনার জন্য এগিয়ে আসবেন। ওনার টোটাল ডিটেইলস ছবি সহ উপরে দেয়া আছে।
If we can start on that point. So you are an expert on that. Why is palliative care so important? There were so many places where you could have worked and done fantastic. Why are you in palliative care, and why do you think that palliative care and geriatric care is so crucial?
Yeah, and I think we can start also by kind of explaining what palliative care is, because I know a lot of the times there can be sort of misconceptions that it means a patient is at death's door, and it's really not, right? So it's really a branch of medicine that recognizes that we want to help patients improve quality of life, right? No matter how long that life may be. So generally we are, experts at symptom management, like pain control is a big majority of what we do. Nausea, addressing sleep, anxiety. But in the context of a serious illness, right, it's not just the physical domains, right? It's also the spiritual, the psychosocial components. And that's where really palliative care can be helpful, because it's not only like the physician, but we also have a social worker, as well as a chaplain or a religious counselor to, try to help people just cope with serious illness.
Right. So is it only, just for my audience to better understand, when do I understand, or when does someone understand that palliative care or geriatric care is suitable for me or my parents?
It's generally, here in the States, it's generally when there's a complex diagnosis or a very serious illness where it's potentially not curable, but not always. Sometimes, we help people with, decisions like, should they get a transplant? Or should they get, their leg amputation? Anything that really will impact their quality of life in some, big, impactful way.
So sometimes it is psychological support, sometimes it's a physical support, sometimes it's a spiritual support, but the overall aim of it is to improve his quality of life, or her quality of life.
Absolutely.
Yeah. So in your experience, can you share an incident where you really felt that you could help this particular patient significantly because you were in this palliative care unit?
Yeah. And like one of the beauties of palliative's approach is that it is very patient-centered, right? So, for example, I remember we were treating a very young guy. He was maybe my age, in his 30s. Unfortunately, he had a stage 4 colon cancer, so the cancer had spread. And we were consulted to help, manage his pain. despite all our efforts in trying to, titrate opioids for pain management, even pain relief through the IV, he didn't have any relief. We even had actually interventional pain, which they did a procedure and they actually cut the nerve, the access to where he was feeling pain, and it still didn't provide a lot of relief for him. At that point, we really believed that there was some psychosomatization of his pain, and we learned, like, exploring more of who he was as a person and his values. He was really having a hard time coping with, a lot of the uncertainty of what stage 4 colon cancer meant for him. He was also, a father. He had 2 little children who he hadn't seen for many weeks because he was hospitalized. And he was also experiencing a lot of guilt as well, which, the spiritual counselor was able to unravel in that. So I think, like, just exploring that and just communicating with him, learning that, a lot of his distress was existential, like, losing the role that he was going to be as a father, right? Like losing autonomy, like all these other factors were actually contributing to his pain. And just having the conversation, right? Like acknowledging his emotions, acknowledging his experience, it actually helped, right? Being very, like, open and honest, having those conversations about stage 4 does mean, that it's a shorter life expectancy, right? Like shorter prognosis. We were sort of instrumental in his pain at that point. So I thought I saw the real value in that holistic approach.
Yeah, that's unbelievable. I mean, in so many ways. So you have your personal favorite quote, and one of them is, "What strikes the oyster shell does not damage the pearl," from Rumi. Why is that? Yeah, what do you mean by that? Like, what do you understand from Rumi by that? That's what I mean.
I understand that there's a level of grit and perseverance that is, involved in just achieving, your dreams or success or whatever that means for you.
Yeah. And that is so true for people who are suffering from severe pain, or in geriatric care patients as well. Grit is so important for well-being and survival as well. And so I really like the fact that how you talked about the importance of improving the overall well-being. So and it is something that just to rephrase my question in the proper way, you already touched on it, but I just want to get a bit deep on that, is that there has been I would say a philosophical shift that happened in how we treat patients, and you can make more comments on that. Like, just to give you an example that I have seen in Bangladesh is that so there are more than 10 psychiatrists full-time who's working with LifeSpring right now, and I have clearly seen a shift. And the shift is, in 40 years back or 30 years back, psychiatry in Bangladesh was mostly about survival. So, for example, if there was a patient, a 16-year-old or 20-year-old schizophrenia patient, right, then the psychiatrist would prescribe antipsychotic in a way that clearly indicates that the psychiatrist is focusing on survival, not quality of life, right? So
there's a trade-off. There's a trade-off.
Yeah. There's a trade-off. And now, when we are looking with the comparatively younger psychiatrists who has completed their MD in last 5 years approximately, be it from UK, be it from wherever, we can clearly see that they are trying to give as less antipsychotic as possible for the client to cure, thinking about the long-term psychological effect of high-dose antidepressant if they are taking it for 10 years. So there's a shift in from only worrying about patient survival to also worrying about its long-term consequence and their long-term well-being. And I guess it happened in internal medicine, it happened in everything. And I believe that it is so important that we sort of, so for example, if a person doesn't have food, they, at that very moment, they don't need psychological well-being probably. But when people have food and when people have a little better psychology, a little less insecurity in their life, they need the concept of overall well-being. Like, so, like 40, 50 years back, it wasn't common for people to have their, surgery for their, let's say, 2-degree tear in their ligament. Like,
yes.
People would like,
yes.
you would survive, you would survive. Now we can clearly see people are not willing to survive. They want to thrive. They really want to go big in life. So that is a philosophical shift that happened, which is fantastic. Can you share your experience in this particular approach?
Yeah, and I think this also parallels the shift that we have in medicine, right? Because as we're advancing in technology, as we have multiple agents now for different cancer therapies. As we have these therapies, we're also recognizing that, yes, these therapies may prolong life, but it also diminishes to an extent the quality of life. Like the perfect example is something like dialysis machines, right?
Mm-hmm.
Dialysis machines, do the job of the kidneys for you, but risk of infection is high, right? Risk of bleeding. Someone has to go to the dialysis center like every, 3 times a week. Their blood pressure drops. So there's so much impact. Although there's prolongation of life, whether somebody wants to, take that quality of life is tricky. And I think in palliative care, like the most important thing we do is communicate, like have an open and honest communication about the gravity of the intervention. And so, it is a shift, like you said, it's a shift in medicine in general, but it's kind of our role as providers in healthcare to share that information to the families and patients and really give them that autonomy, right? Like, is this something that they want, with understanding the risks and benefits?
Yeah. So, so if I ask a very different question about how does a patient decide when or if they want to pull the plug because of the pain?
Yes, it is a very.
So there is definitely the sort of the religious part,
yes.
where and the spiritual part, and that's quite complicated. I went on it like. When does the Islamic preacher thinks that it's okay to pull the plug or not pull the plug because of 2 reasons. One is the patient is in pain or the patient is semi-alive.
And I actually, like in palliative care, I learned a lot about Islam as well because, we work with imams for our patients and one of those things is withdrawal of mechanical life support okay. So one of the things that I learned is that in Islam, like suffering, one is not viewed as a punishment. So, some people cope in that way and they feel that it is, but it's not viewed as a punishment. And it's actually, in the case of suffering, pain medication is allowed. Withdrawal of support is allowed. But as you said, it depends on the situation. Is, support doing more harm than good? But suffering is really looked at with a lot of grace and mercy in Islam. And even it, talks about, ridding of sins. So I think it's a, we do, take that consideration into account when making these, tough decisions. Yeah.
So from a purely specialist point or consultant point of view, when do you say it's okay to pull the plug for the patients, or it's their choice? Because they are semi-alive, let's just say, semi-alive, semi-dead. So what's sort of the aspects that you look at?
So in our sort of ethical legal system in the States, it is purely, there's a large weight of patient autonomy. So they, in medical literature, what makes a case futile, right? When is this completely unnecessary? There's actually no good literature to describe it. All of those definitions are based on patient values. So we do actually leave it to the patient, and if the patient is incapacitated, like they can't speak for themselves, then it would be up to the family. But it is tough. It is very tough. It can be quite complex. If it's absolutely that we know that, a patient is, like, let's say, brain dead, but they're on life support, and let's say family does not want to withdraw, then we would have like our ethical and legal team involved. So, but right now, it gets complicated, right? It gets complicated, yeah. But right now, it's based on patient's choice, yeah.
Yeah. You were in California for quite a long time, and here is something that kills me about California. Try to help me on this. And definitely California has amazing things, and but here is something that I don't find amazing, and that is that. So we have more patients from like psychological support, people reaching out for psychological support, patients. We have more patients in USA than we have in Chittagong, we have in Sylhet. So more patients reach out to us from in New York and Texas than people reach out to us from Chittagong. That's something that we, that we are happy about, because definitely people from New York and Texas and sometimes more, educated about mental health, and they look for people who understand their context. Okay, all good. But something that I don't understand is, so let's say there is a patient of schizophrenia in California. Let's just imagine that his name is Abul Kashem. And Abul Kashem has a history of schizophrenia. He's clearly schizophrenic. And when he have his psychotic episodes, his children and his wife is not safe. So the wife goes to the, psychiatric center and psychological support center and says, you know what, bring my husband. And they're like, no, we won't bring your husband because it's not his consent. And he's like, what should I do? I'm not safe. He said, go divorce, file for a divorce. And said, I have 2 kids. When he's good, he's good. But when he's not good and he has a history of that, just take him to the hospital. You know what I mean? They won't take him to the hospital because it's outside his consent. And I have seen, and our psychiatrists, usually we see these cases as both psychiatrists and psychologists sitting side by side. We have seen more than 50 cases where there was a divorce which was unnecessary. There was a incident that was completely unnecessary. Some people are, drug-induced psychosis, many things. But patient consent. The world is about patient consent. I'm like, how do you expect a schizophrenic patient to, if the patient is completely stable, then he is not schizophrenic. If a bipolar patient is completely stable for 15 years, then life is good. Life is not good. That is why they're reaching out. And how are you? And another
it's very tricky. Yeah, because psychiatric illness is not necessarily mean, right? Like they cannot make their own choices. So
they play safe.
Unless they're a threat to themselves or a threat to other people, like harming other people. That's, in most states, they can take some action, but otherwise, no. Yeah,
but it does, ethically, I don't understand this. It's because, I'm not suggesting that anyone should arrest someone else. It's not the point, but the point is that there should be intervention for people who are psychologically not in their own, not in full control. And there are evidence for that. And at least there should be an effort to explore those evidences. Right. I can understand that sometimes the wife cannot be true, that I understand. But the thing is, there's no, like for domestic violence, as an example, there is clearly a lot of effort to go out, seek evidence and all of that. Right. There's always someone, who's looking after domestic violence. So that's good. You are reaching out to people, whether there's some family abuse is happening or not. That's great. But regarding, let's say, schizophrenia, bipolar, psychotic episodes, is you are expecting the patient to come to you and say that they are suffering from psychotic episodes. Like, it doesn't work,
Yeah, I think because this patient population is so vulnerable, and they can also be exploited too, right? I think that's where, it can just be very tricky. So I do feel for them a lot. I feel for them. Yeah.
Yeah. Another very interesting thing is that when teenagers drug addiction problem, and they'll go to the therapist and they'll be, it is very strict that nothing will be heard or discussed with the parents at any cost. That's also something that I wonder, like, but that if you're always looking for consent from a 15-year-old, like, what are you expecting from a 15-year-old? And there are so many people who are dying from drug overdose in all parts of USA. It's sad to see.
It's very sad. Yeah. And, it goes back to, like the line between protecting, the individual's rights, versus like exploiting a vulnerable population. So those are very, very tricky matters. But I think like in terms of just like ideologically, here in the States, like, patient autonomy is held Everything. In high regard.
Yeah, but some part of it I don't understand from a purely philosophical or psychological point of view. It sometimes I feel like it does more harm than good. And I have seen in family therapy some really unwanted incidents happening because of patient autonomy and because many like really complicated cases of so as
and part of the problem is like once let's say you give a certain governance or authority to someone, right? Like it's a very fine line because authority again can be exploited to the vulnerable. Like what if somebody is psychiatrically ill, what if somebody just puts that diagnosis and then do they lose all their rights to do anything? So it's I think there's a fine line.
For sure, there needs to be a balance. I mean, But I do think that the patient's caregiver, and the psychiatrist, all of them needs to have a stake in what should happen when there is a psychotic disorder or a potential drug overdose case for a teenager. It shouldn't be only that one person, because we can clearly see that he is not fully stable.
Right,
so I mean, so it's very interesting, because even in our religion, so three people doesn't have any sin: one who's sleeping, one who's child, and the one who doesn't have control over their mind. So even if they commit something, then so even in there, so there is that incident that you should support him or her, because he doesn't have full control over himself or herself. You don't take her in our religion. You don't take his judgment in a crime case, because he doesn't have full control, and all of that. So it goes in depth. I think that in certain legislations, they're just, it's very convenient to say, your life, your right, do whatever you want, but it's oversimplifying the situation.
Yeah.
Like, because if you think of suicide as well, discussing about suicide is also becoming difficult. That is it patient's right to commit suicide? Then if it is a patient's right to commit suicide, then what are we doing anyway? You know what I mean? Why are there like a billion?
Well, it wouldn't matter because they're gone, right? Like that's why it's such a hard but I get what you're saying. Like in Islam, for example, suicide is absolutely
discouraged,
right?
Yeah. No, but what I'm saying, that even if we leave religion for a second, even if you think, like, it's so amazing, that it's so interesting and somewhat paradoxical, is because American Psychiatric Association or British Psychological Society are trying so hard to reduce the number of suicide. But at the same time, if the entire legislation is about its patient's right to commit suicide, then at a certain point, it's difficult if the community is not able to really help, because many of the suicides are happening because of drug overdose, because of drug-induced psychosis, and all of that. So if it's like, you know what, we will talk about preventing suicide on the billboards, but if you want to jump, then it's your right, and no one is going to try to strongly discourage you on that. And so I find that somewhat paradoxical, in the sense that definitely we can't force anyone to not commit suicide, but there needs to be some empowerment by the community that we want to protect our own people.
Yeah, and it goes back to, making sure that there's good mental health resources and, access to healthcare, and enough money to provide that support as well. Usually if people are at risk of harming themselves, so I know, for example, in Maryland, you can actually keep someone in the hospital if you think that they are going to harm themselves. If you think they are going to suicide, you can actually essentially restrain them in the hospital.
Yeah, that's fantastic. If we go a bit on a different dimension now, is that how do you keep yourself psychologically strong and stable, given the fact that you are always firefighting, you are always seeing people in their deathbed, and it is very stressful. So let's talk a bit about care for caregivers. So, and we have seen that in many countries, and in Bangladesh as well, many psychiatrists and psychologists and people who are strongly involved in palliative and geriatric care, they themselves become vulnerable, like really, really vulnerable. So how do you help yourself?
Yeah. Wellness is fortunately a hot topic nowadays, right? Like well-being and just, mental care. So I think, but you bring up very good points, especially through this pandemic where, healthcare workers have been sort of overstretched. and also they may be caring for, their parents at home. We're the sandwich generation, right? We take care of, both sides. But for me, I do participate in therapy. I think that it's been, very valuable in terms of learning like coping skills, especially with all the, complex family dynamics I see with my patients and at the end of life. I'm very lucky to have support from, my mom and my husband. Definitely lean on them. So, and I think also going back to the very basics. So part of things that I do is, sleep, eating right, exercise, like the very basic things for your physical health. So.
শরীফুল ইসলাম একজন দিনমজুর, দিনাজপুরে ৪৫ বছর বয়স্ক। উনি প্রচন্ড অসুস্থতায় খুব কষ্ট পাচ্ছে, তার জরুরি ৫-৭ লক্ষ টাকা দরকার চিকিৎসার জন্য। আমরা আগের যেই অ্যাপিলটা নিয়ে কথা বলেছিলাম, যেখানে আপনারা এখন পর্যন্ত অলরেডি প্রায় ১.৫ লক্ষ টাকা আপনারা হেল্প করেছেন। আজকেও আমি অ্যাপিলটা করছি, আমি ইয়াহিয়া আমিন ৫,০০০ টাকা ডোনেট করছি এবং আমরা আশা করছি আমরা সবাই যদি একটু একটু কন্ট্রিবিউট করি, তাহলে ওনার জীবন, ওনার পরিবার সবাই এই ভয়াবহ অসুখ থেকে মুক্তি পায়, যেটার কারণে একটা পরিবার এবং তাদের সন্তানরা সবাই বেনিফিটেড হবে। সো ওনার জন্য এগিয়ে আসবেন। ওনার টোটাল ডিটেইলস ছবি সহ উপরে দেয়া আছে।
Yeah, I mean, I do think that you mentioned it very, concisely and appropriately, is that it is so just to be very aware that just because you're a doctor or you're a physician, don't think that you're free from all the worries. And because a large portion of my client base are actually doctors and physicians and health workers, and I have seen that they just so comfortably accept stress burnout, which they shouldn't. They're just like, oh, I'm just giving my life away for my patients. No, you're not supposed to do that, and you're just reducing your lifespan probably by doing that. It's not helping anyone.
No, absolutely. I think it does take self-awareness, right? And a bit of mindfulness, understanding like boundaries are necessary, right? Like you're not being mean by saying no. And I think
you have a capacity just to be aware about your own psychological capacity to deliver.
And I think you really need to like value, right? Like value your health, to like understand that like in order to take care of others, you have to take care of yourself first, right? Like in the airplane, first put on the oxygen mask, then put it on for your, child. So, I think all of that.
Yeah, I'm also one of the point that is important. I would love to know your experience, is that when we are trying to reduce stress, or when we are trying to be more mindful, when we are trying to be, improve well-being, relationships are like personal relationships are very critical. I mean, like you said, you talked about your mom, you talked about your husband and how they have supported, especially when you are drained out or when you are tired or exhausted with all the meaningful things that you do. And I do think that sometimes people underestimate that support. It's they do think that as I am financially independent and I have a good job, good life, and I can just buy some therapy sessions and I'm just good by my own, but really it's not possible to replace the emotional and psychological support that a very personal family relationship bring on the table.
I think what you're saying is profound, because like I feel like in these last 3 years, like doing palliative medicine, it's an important lesson that my patients have taught me. So, right, like constantly being faced with their mortality, it reminds me of just kind of the finality of time. And, my patients teach me like, at the end of life, they're not caring about how much money they have, materialistic things. They're not caring about status. They are, thinking about their relationships, right? Like they're feeling despondent or sad that they didn't spend more time, with their siblings. They wish that they cultivated more connections. So I think that's something that, certainly undervalued in, our culture, unfortunately. But it's, it's sort of in my face all the time. So maybe that's why I'm reminded for it.
Yeah, but I'm also reminded when I'm doing all the family therapies.
Right.
I have seen enough, people who have achieved a lot of material things, but at the same time, they're extremely sad and emotionally bankrupt. And this whole idea of I'll just buy some therapies for myself, just like I buy food for lunch, it doesn't work. Therapy is not the solution to all the problems. Like a therapist cannot. I'm a therapist, and at the same time, a therapist cannot. It's not no one is a magician. There is some emptiness that a therapist cannot fill. So, for example, they can get you out of a major depressive disorder, but they cannot entirely make you happy. And these are two very different things. So one is dragging you out of a major depressive disorder or from severe anxiety. That's possible by a therapist, by a psychiatrist, or combination of both. But they cannot make you fully happy. And what can make you fully happy is self-awareness, healthy relationships, good food, healthy sleep, like meaningful purpose, and all of those deeper questions.
Absolutely. I think there's a lot of parallel in palliative medicine too, because, we can't always get a cancer pain to zero, right? We can't always make death go away. The inevitability of death is going to be sad inherently, right? So there's a lot of similar feelings for that as well.
So when we are dealing with a lot of patients who are in their deathbed, and you are dealing with a lot, where do you see that? So among different cancer patients, how do you see that the psychological strength or the psychological support being, or the spiritual support helping patients? Because you observe it. In my observation, I have seen that resilience among cancer patients, psychological resilience, matters so much in their recovery. What has been your experience?
Yes, so I would agree with you. Resilience. I think it's important to have hope and goals. So hope doesn't have to look like, hoping for a cure, but, one can have short-term goals, for example, right? You spoke about spirituality. So that, that can be fundamental, to people's worldviews, right? It's such an important value, which helps people just process why they're suffering or why they're going through this. So it's certainly a source of strength for them. I remember I had a patient, for example, who had advanced cancer, and, naturally he was fearful of death, but he would not want to engage with the medical team at all. He wouldn't want to, he was basically in denial. And he just worried that talking about it would mean, just giving up or losing hope. So that's where, his chaplain, pastor, was able to talk with him, and he was very, very much faithful. And that sort of helped us connect with him to, open up more conversations. So I think spirituality is certainly helpful. One thing I will say is that, there's sometimes a paradox in faith. So sometimes we see that people who are more faithful, they have a harder time accepting that their illness. So there's a joke, actually, I don't know if you've heard of it, but it's a man is on a sinking island, okay? And another man comes on his boat and he's like, hey, come on, I'll save you. He's like, no, I've been praying all my life. God will save me. That's okay. And he's still sinking on that island. And the water is up to, his waist now. And another man comes on a boat and he's like, come on, come, let me save you. And he's like, no, God will save me. And then, he sinks and he goes to heaven and he's like, God, I prayed to you my whole life. Why didn't you save me? And he was like, God says, save you. I sent you 2 and 3 boats. You never got on it. So it's, there's a paradox to faith as well, which is interesting.
Yeah, for sure. So much of faith is about how you understand it. So much of faith is about how you, you embrace it in a way that improves your own well-being. Yeah. So if I go a bit deep on that, so for example, one of the top physicians, his name is Dr. Balboni. He's an MD, MPH, FAA, HPM. So she's very well known, and she has this famous quote, and that is that. Spirituality plays a major role in patients' well-being and decision-making. And she talked a lot about many researchers on that. So in Bangladesh, is that no spiritual leader is going in the hospital, and no hospital is bringing a spiritual leader, for sure. Wow. Although Dhaka has more mosques than any single city in the whole world, right? But there's this divorce between spirituality and hospitals, which is very interesting.
Yeah. Go ahead.
So what is the appropriate role of the spiritual leader in complementing the physician's support in palliative and geriatric care?
So, as I said, it is such a fundamental part of people's worldviews. So, when they're trying to understand, the why of their disease, right? Or if they have regret or guilt, it's often a time where, people are reflecting on just the meaning of life. That's where the spiritual providers can be instrumental. Spiritual providers are not necessarily religious. So, people find spirituality through religion, but also nature, different communities. So it really depends on the individual, and we just try to honor whatever they, whatever they follow. But, most of the time, spiritual providers would, for example, maybe sit with them and pray, absolve their guilt. I've heard, providers also share that God loves you no matter what. So really, words of affirmation, a way that they find peace, I think is the goal. So.
Yeah, I think that there needs to be I would say that accommodating nature on both ends, both on the physician's end and on the spiritual leader's end. Right. In Bangladesh, I can clearly see a conflicting attitude. I know all mindset in Bangladesh, where the physician thinks that why would a spiritual leader enter my patient's room? And at the same time, the spiritual leader is like, you know what? no doctor is going to be able to save you. So you know what I mean? Like, so they're in a very decisive, conflicting zone. And this is something that I believe, and I hope that in Bangladesh, we can make a bridge and not a wall. And this is so important because a large part of Bangladeshi population is deeply spiritual in their nature, and they seek God, Allah, and they seek physician as well, in appropriate ways, definitely. But unfortunately, so many of the physicians and so many of the hujurs and imams and spiritual leaders are not in good terms, unfortunately.
Wow. Yeah, and I think, at least, the role of the provider here is just to recognize it and acknowledge that it's such a strong component of people's lives. I learned things like, for example, if a person can't do oju when they're, sick, that they can actually touch what's called the tayammum, I think, is the dry stone, things like that. I learned that, it's valuable to, a Muslim should recite shahada at, near death. And then, time of death, patients, eyes should be closed, their body should be clean. So there's a lot of things, I think, at least in the role of physician, that's important to recognize, in their patients. So.
Oh, absolutely. And primarily to, better understand death, and, just the fact that for so many patients, just to understand that death is fundamentally not something horrible. Rather, death is a journey from one place to another, and the future can be more meaningful than what it is now, and pain-free. So in one of our famous narrations from our Prophet, we know he said that for someone who believes, death is a beautiful gift. So, and there are so many people who do want to believe and do, so, I mean, definitely it comes down to what patient believes, but just to empower him, help so many of the patients who are in deep trauma.
Absolutely. Like, as you said, I think that's what I meant when I said instilling hope, because they can envision, not just potentially their afterlife, but also, imagine a world where they're not in, and, having hope that their children and their loved ones are taken care of, after they've passed on. So a lot of peace, and hope that spirituality can bring at that point. I'm curious to know, like, what is the perspective of, death and serious illness in Bangladesh? Like, how is that? So, for example, like here in the States, I think death is a very taboo topic, and, people feel very immortal because the media sort of sensationalizes a lot of, medical technology that people can be, brought back from miracles. So I'm just curious, like, how that sort of perceived in Bangladesh.
So in Bangladesh, I would say that still both the Muslim population and the Hindu population. So Muslim population is approximately 80%, and Hindu population is approximately 15%. Most of them are deeply spiritual in different ways. So they are not in denial of death. They are not looking for immorality at all. What they are looking for is a meaningful conclusion to their life, and then what comes afterlife, at the afterlife. And so they are not seeking immortality. They are seeking meaningful afterlife. So, and I do think that psychologically helps a bit, because all the researchers show that healthy spirituality helps in a community to reduce suicide, reduce long-term depression in different ways. Definitely spirituality is something people can approach in different ways, but just the fact that they can answer the unknown whys of life. Definitely, we cannot prove it scientifically because of our own intellectual observational limitations. We don't know why. Scientifically, we cannot prove afterlife. We cannot disprove afterlife. It is something that we just don't know. But the belief of afterlife, if it is helping someone towards well-being, let it be. Let it absolutely be, because for sure it's not harming anyone. So that is the overall approach in Bangladesh. But the problem, one of the rising issue in Bangladesh that I see in this particular field is that the different segments of the society doesn't respect each other. So the people of the mosque and the people of the hospital doesn't go well with each other. Although a large number of people of the mosque go to hospitals and a large number of people of the hospital goes into the mosque, but they don't really gel well in places where it requires a multidisciplinary approach, right? So I was talking with one of the cancer specialists in Bangladesh. I won't name him. So I talked about briefly the role of a spiritual leader in the 4th-stage cancer, and he got mad at me. You know what I mean? So and he, you know what I mean? He was like, I have studied for 15, 20 years and then practiced for 30 years, and now in my patient's treatment, I need a random spiritual leader to help him. You know what I mean? So there is that. So
the ego.
And there is that. And then there is that. And then there will be a few, not a lot. There will be a few spiritual leaders who are like, go there and see if they can, deny death. You know what I mean? There is that unfortunate beef. So in America, you see that spiritual leaders are going to hospitals, going to different places, working with lawmakers, going into the even jails. They have spiritual leader. Yeah. All the rehabilitation center, you see spiritual leader. But in Bangladesh, it is a taboo that needs to be broken.
Wow. Yeah, it's like you said, there certainly needs like a multidisciplinary cooperation, and like that's, how we operate with the physician as sort of leading the team. But can people overstep their roles? Yes. I mean, that happens in lots of institutions, but it certainly makes it challenging if there's not like a nice gel with all
so in Livestream, we are trying to sort of merge it with the best of our ability. So we are, let's say, opening up mental health for imams and spiritual leaders, a free training so that they know what it is about. Because sometimes what happens is, again, in mental health, sometimes what happens is if there is a psychotic patient, then the spiritual leaders always look at from a exorcism perspective, psychiatrist is always looking at a psychiatric perspective, obviously, and the patient being spiritual and being psychotic is completely in chaos. You know what I mean? So no one is peacefully like, what, take the necessary psychiatric intervention and do whatever you like to do in your spiritual from your spiritual interest. No one has that balanced empathetic approach. It's like you do this and that is a prejudice. You know what I mean? So yeah. So yeah, it creeps in more tension, unfortunately.
Hopefully not in all spaces. Hopefully not.
So how is it? Like I have seen that institutions like John Hopkins is working a lot on the anti-aging aspects. A lot of investments are coming in there in that space from billionaires and all of that. Do general people really hope that it's going to work out? Does that hope help them?
Yeah, and actually UCLA has a lot of research on anti-aging and also dementia. So like a cure for dementia. But like, to be honest, a lot of it is more theoretical and so more on the molecular level. So in theory, right, like, for example, telomeres are proteins that, part of aging, and they decrease with the lifespan. In theory, they're seeing that they can manipulate that, but whether that clinically it would manifest to, slowing down aging, I think is still kind of up in the air.
Mm-hmm. Yeah. I think that it's a bit overhyped by the media.
Yeah. There are a lot of cosmetic and like external procedures for anti-aging. Yeah.
Mm-hmm. Mm-hmm. Is already like I have seen that John Hopkins is involved in a lot of research related to ecstasy and hard drugs, helping people reduce pain, severe pain. So psychedelic drugs.
Yes.
So is it already in use, and how is the efficacy?
Yeah, that's a great question. So psychedelics are still in research. We do use something called ketamine, which is a dissociative drug, and it is FDA approved for using it for a specific type of pain. So not just general end-of-life pain. It's called neuropathic pain, so something that's a specific type that affects the nerves, which we do use it. We use it for in the hospital. Yeah, with good efficacy, I would say.
Mm-hmm.
So but it's typically used as an anesthetic in certain doses, in higher doses, but for pain, it's a much smaller dose.
Mm-hmm.
But we can see, sorry.
No, please, you can see.
You can see, some dissociative effects sometimes. So like the more, hallucinations and some, psychomimetic effects with those drugs. And it's just kind of balancing, pain control and what's acceptable in terms of side effects.
Mm-hmm. No, that's great. That's great. So I have a fear, just a fear, you know what I mean? I don't know whether you have that fear or not, is that what happened with opioid and the way the crisis broke out. And I feel, and also now hard drugs related to opioid, and how ecstasy is fantasized in different podcasts and all of that. Do you fear that the way media is romanticizing psychedelic drugs, there can be another outbreak of overdose of hard drug because the black market and the white market somehow becomes the same color? At least that is what happened in last.
That's a very poetic way to put it. But yeah, it's a serious threat, right? I think we had one of the largest number of fentanyl doses last year. But, it's hard because in the palliative population, it's very acceptable to use these hard drugs because it's like necessary. Yeah. So
it's necessary. It's curated. It's in a strictly controlled environment.
Absolutely. Absolutely. So a lot of the, overdoses, they're not, from this cohort. So that, there's
the curious teenager cohort. Yeah.
But it is a huge problem nonetheless. Yeah, I hope that there's more, there are more stricter rules and regulations in place in terms of policy, like being able to get these medications.
I see patients in Dhaka, with all honesty. I see patients in Dhaka taking ecstasy and all of that. And they're like, oh, John Hopkins did a research and say, it works. And UCLA did this research, and Joe Rogan said in his podcast and all of that. And I'm like, man, you know what? You are not, you haven't read it properly, and you haven't seen what they said properly. You are just enjoying something that might, be devastating for your future completely. And I can clearly see a rise of hard drugs in Dhaka. It's definitely illegal for sure, but the dark market is very strong. And I guess it's same for India, Pakistan, Sri Lanka, Thailand, and Burma, and all of that. And it just makes me, because it is romanticized in generic conversations in such a way, it's just a pain reliever, just like just.
Yeah, and I think you hit it on the nose, like you said. Like if you actually look at the literature, it's saying that it's helpful for this specific type of patient that needs it. So it's unfortunate that it's sort of sensationalized in that way. Yeah.
So thanks a lot, Dr. Ivy Akhtar. I had a fantastic time talking with you and hearing your views on different things. And I was somewhat happily surprised to see that we agree. And although this is the first time that I'm talking with you, we echo so much alignment in so many of our perspective. So it's great to see. And I really hope and pray that you do fabulous throughout your life and support a lot of patients who need such a critical support. So we are completing our podcast here.